Hello, everybody, and welcome to Airway Circle Radio. I'm Nicole Goldfarb. I'm a speech language pathologist and certified orofacial myologist, and I am your host today of Airway Answers, expanding your breadth of knowledge. And our goal here is really to open up the airway space. I like to say little puns like that, but really what we're doing is expanding the airway literally, and also the space and the form for talking about airway issues and how to really help the breathing of people. So today we have two amazing specialists here joining us from two sides of the United States. How wonderful that we can bring them both together. We have Dr. Tracy Nguyen and Dr. Richard Ting. So I'm going to introduce them, and our topic today is talking about maxillary skeletal expansion. And these are two specialists in this area. And I actually had the MSc myself through Dr. Ting. So that is why I have the diastema that I'm showing off today. Okay, so let's talk first about Dr. Tracy. She maintains a private practice 30 minutes outside of Washington, D.C. in the Northern Virginia area. In 2015, she was accredited by the American Academy of Cosmetic Dentistry. And in 2016, she was honored with the top 25 women in dentistry. Woohoo, Dr. Tracy, that's wonderful. She's one of the key opinion leaders in the Wellness Dentistry Network. The focus of the organization is to merge the gaps between medicine and dentistry and understand the oral systemic connection. After attending one of Jeff Rouse's courses in the talking about dental malocclusion and comorbid airway and sleep issues, she became interested and began to mentor in the airway workshop with Jeff Rouse. In 2016, Dr. Tracy developed the Sleep and Airway Group. And then in 2020, she co-founded ASAP, which I feel like is really spread. Like that's very familiar to me. I know you always post about that. That's the Airway, Sleep, and Pediatric Pathway, which is actually an online mini residency for pediatric dental sleep medicine. And I'd love at one point to talk about that, Dr. Tracy, because it seems like a wonderful resource for dentists, and you can explain about that later. And Dr. Tracy also has done she's a scientific advisor for the prestigious Advanced Dental Education Center at the Poise Center. Dr. Tracy's mission is to develop a better understanding of the complexities of the disease of sleep disordered breathing and bringing like-minded professionals together to diagnose and treat such issues. So we are so fortunate to have you here today, Dr. Tracy. And then also we have Dr. Richard Ting. Dr. Ting has been creating beautiful smiles in Rancho Santa Margarita, California since 2005. He's an orthodontist and he specializes in the MSc approach. So we have a top MSc specialist here with us today. Dr. Ting received his doctoral degree from the University of Southern California in 1991 and began to practice general and cosmetic dentistry for 8 years. And then his passion for dentistry led him back to New York University, where he completed his postgraduate degree specializing in orthodontics in 2001. Dr. Ting actually comes from a family of orthodontists, a younger brother who's a graduate of Harvard University and the chairman presently for UCLA's orthodontic department, and also brother-in-law who's is that correct, Dr. Ting?
Yes.
Okay, and a brother-in-law who's a graduate of UCLA and also an orthodontist in Manhattan Beach, California. Dr. Ting is one of the few elite orthodontists in the nation who has mastered the use of the MSC, the Maxillary Skeletal Expander, and he's perhaps one of the most experienced in this technique in the world. So in addition to his mastery of this technique, he actually mentors and teaches other orthodontists and dentists who fly in from other states, come from all around the United States, to learn about the MSC and how he implements this technique for airway. Dr. Ting also has a specialty and a true understanding of clenching related issues related to TMJ problems. And he is a top 1% in the United States Diamond Plus Invisalign provider. Dr. Ting is really an airway and functional orthodontist who focuses on treating airway issues in both children and adults. And his goal is to really not leave patients with a lifetime dependence on appliances and altered bite, but really resolve such issues and problems. So I'm so excited to have you both here. today. I learned of Dr. Ting from Dr. Tracy, and you both have helped me so much in my personal journey, my family's journey, and my understanding of airway issues and MSC. So let's just get started by talking about what is the maxillary skeletal expander. Dr. Ting, do you want to explain what it is and how it works?
Okay, maxillary skeletal expander, we also call it MSC in abbreviation. MSC device is invented by Dr. Moon, Dr. Wong Moon. He's a program director at UCLA, previous program director. The device been in the market at probably about 5 to 6 years. The device is different from the regular expander in the sense that when we expanded the palate, the conventional expander that 99.9% of orthodontists use are there to support the expander. So when you expand your maxilla, then a majority of the time, actually the teeth are being pushed out instead of maxilla being expanded. So you don't get a true expansion unless the patient is a very young age, for example, 7, 8 years old. Then it's still possible to get some skeletal expansion. But when you become a teenager or almost teenager, when you expand, most likely you're going to get a lot of teeth tipping. So maxillary skeletal expander, it's the same philosophy of expanding by turning a little screw in the middle. However, because it's bone anchored on the palate directly with the 4 TAD, or some people put 6. TAD means the little screws to anchor into the palate. Therefore, when we expand it, the majority of expansion actually achieved by expand the palate itself instead of flaring out the molars or the adjacent teeth.
Mm-hmm. Is there any dental tipping involved when the MSC appliance is used?
They still do have some dental tipping because during the expansion, a lot of time, the 4 screws supporting the MSC, which is called TAD, sometimes they do drag a little bit or tip a little bit. So you do get some molar tipping, and you get some also adjacent teeth tipping, depends on how your device is designed. But however, tipping-wise is way, way less than teeth-supported device alone by itself. Okay, and also an experienced practitioner like Dr. Tracy or me, we usually can control those tipping after we expand them. We can have a way to reverse those tipping and put your molar back inside the bone. So tipping-wise, on my hand, is 0. Okay. You will have initial tipping, but it will be corrected afterwards.
So it's actually the skeletal, the bone is widening and growing.
Yes. Splitting in the middle and then fill up with the bone.
Okay. So Dr. Tracy, what ages do you use the MSC appliance on?
So as a general dentist, I have to be very careful on how young I can use it because MSC is very controversial in using it on children. So I'm very jealous of my orthodontists like Ting and Illya that can use it on 5-year-olds because many orthodontists would throw me under the bus if I did that. My youngest is probably, I want to say probably 14, 15. And I did it on, because I treat a lot of children with obstructive sleep apnea. So there's when skeletal expansion is a need and a guarantee for me, that's my go-to. But my orthodontists like Ting and Illya, they're using it on kids as young as 6 and 5. And unfortunately in my area, I would be thrown under the bus. I'd go to ortho. I joke around and say I'd go to ortho jail for it. But I think there is a place for it. Richard, what's the youngest you've done it on?
The youngest I did is 7.
Yeah.
Late 7 years old.
I would love
but it's absolutely needed.
Yeah, and there has to be the right diagnosis for it. You really have to justify using TADs. There's a pretty good study out where the mean age is 9. And Guimeno was in that study, and they looked at tooth-borne expanders versus TAD, which is TAD, bone-borne expanders. And they looked at children suffering from sleep disordered breathing. And they said, and wanted to see, okay, is there a difference? And they found in the study that there is in fact a difference in respiratory distress, sleep, quality of life, nasal obstruction in children that had TADs used, TADs. And in this study, the mean age was 9. So obviously it's like one study and there's not a lot of studies looking at this age group. But in conclusion, in the study, they found that the occlusion was the same. So there's no significant difference in treating, treating with TADs or without TADs, but the significant difference was in the breathing. And that's one thing that most orthodontists, it is accurate that you probably can get away with not doing TADs, but if the diagnosis is respiratory distress and nasal resistance, one would consider using something that would guarantee to have skeletal expansion.
That makes sense. So it's like you would choose to use such a bone-borne appliance on a younger child if they're having nasal issues.
Yeah.
Yes.
So like mouth breathing, congestion. That's the kind of one of the factors that would say let's go that route versus RPE or something tooth-borne.
Yes.
Yes.
And I would say like more progressive orthodontists like, Richard Ting, Mariana Evans, Illya in New Jersey, like they don't really need a why to use TADs. It's just a better technique. Mm-hmm. Now, obviously, this is not mainstream orthodontics yet. And, we hope to see that in the next 10, 15 years. I mean, we're definitely pushing it. But again, this is not mainstream that's taught in the schools to do it this young.
Mm-hmm. For Dr. Ting used the MSC on my son when he was 8, like almost 9. And he used to have to use Flonase every day and would wake up with a congested nose every morning, which was a sign of obstructed breathing at night, is that AM nasal congestion. And he's off Flonase and doesn't have congestion in his nose. And he can even describe and say that he doesn't have that anymore. So that felt, that was a really good choice, I felt. Are there any like negative implications of doing TADs on children? Like when they're younger, is there research showing there's maybe a problem with the maxillary bone in the future? Or we don't have enough information by drilling into the bone? Does that cause a problem when they're older?
I'll let you answer that, Richard.
Okay. So
no, but
so one thing we'll add to that is the other implication of doing MSC or CAD supported expander is when the patient already presented with a pretty flared posterior the back molars. So if the younger patient presents to my office, like the one that we did on the late 7-year-old, is because he came in a really narrow arch and the molar is already flaring outward quite a lot. And I can't afford to flare those molar out even more. Then we'll literally push those molar out of the bone. That will cause a tremendous amount of damage for the kid in the future. So in that case, the parents actually is a dentist that worked, my referral dentist. Both parents are dentists working in the same building, and then I explained to them the reason, and then we accept the MSC. And the result is beautiful. So molar actually get tipped back in to the bone after we expand it, so you get a very healthy arch and straight molar. So in that case, it's also a contraindication of use conventional expander on a younger kid if the molar is already pretty flare outward. Now, the question you asked about, is there any bone damage? So far, with all the cases I did, I have not seen any damages. Now, usually those little holes that on the younger kid, I don't use 4 TAD to support. If the kid is about 9, 10 years old, a lot of time I always use only 2 front one, and where the bone is a lot more solid. Once we put it in, and when we remove it, Dr. Tracy will know the little hole actually heals up within 1 or 2 days. Okay, now the bone's supposed to heal up accordingly, and especially for younger kids, I really don't see any issues with that. And then also we finishing case, we follow up with the CBCT. We never see any significant changes in the bone, and I never have a case of sinus perforation or any perforation cannot heal up out of 570 cases. So if it happened, I'm pretty sure one day there's one case, one patient will happen. There's always the exceptions. But out of my more than 570 cases, I think more than 580 cases now, I never see anything problem with the healing.
Okay. And for my son, he also had his molars flared out because we got really early airway treatment when he was 4. And there was a lot of dental tipping. So that was another reason that the MSC was chosen for him. So this is great information. What about older adults? What's the oldest age you can do MSC on, and how does that work? Dr. Ting, do you want to?
Yes. My oldest female adult that successfully expanded 69 years old. I know Dr. Lipkin expanded some male 60-something-year-old successfully. And so to me, age is no limit, but only the factor that I worry about is if the patient's on any kind of osteoporosis medications that will prevent the bone from remodeling or new bones are forming. So those are the only contraindications. So when we see it, for example, female patient, a lot of older female patients are on those medications for osteoporosis. So once they're on it, basically any kind of orthodontic movement or bone changes are impossible. Even dental implants are impossible. So those are the only factor that stop me from doing it. The other factor that I will consider if patient have any healing issue, for example, they're uncontrolled, uncontrolled diabetic problem or immunodeficiency, then those patients may have infection issues. Okay, so that's the patient I will be aware of. Perhaps choose not to do those, provide MSC treatment for those patients because the medical condition. But age-wise, I really do not think it's an issue. What do you think, Dr. Tracy?
My oldest females, I have 2 that are 67-year-old female, and both of them are on CPAP. Men, I'm like 50-50. Probably the oldest male was like 32, but again, I had to use multiple expanders. I think the key here is more about being honest about your results and predictability. I think there's this mindset of being burnt out using multiple expanders. Is it really worth it to go non-surgical versus being predictable and do it surgical? And sometimes with the surgical techniques today, you can, the traditional surgical cuts are less. So there's less surgical risk now. So I think that's a discussion that the patient has to have with the dentist or orthodontist and the surgeon. I just had a consult with a patient, and he was 28 years old. And I said, yeah, we could attempt to do this non-surgically, but if you want predictability, it's surgery. And so I think for patient standpoint, like this quest to do everything non-invasive, non-surgery, you have to ask yourself, is it worth it? Because you lose the predictability.
That's a great point. So can you explain more about what type of surgery we're talking about? So regular MSC is just, like Dr. Ting said, just putting the screws in, turning the appliance, but then what are the surgical options, Dr. Tracy?
So I'll go over it briefly. So traditionally, before the invention of the TADS, the only way we were able to expand adults was a tooth-borne expander and a surgery, and that involved like 3 surgical cuts. One of the surgical cuts is way in the back where there's a plexus of blood vessels, and that has the most surgical risk. With the invention of TADS, those little bone anchors in the palate, we're able to reduce the most dangerous cuts and the most dangerous cut. So now that procedure actually started out at Stanford called DOME, distraction osteogenesis maxillary expansion. And that is a combination of an MSC-like appliance with TADS with a minimal amount of cuts. And that's where the surgical cuts have been modified. And that's what I think Dr. Ting and his surgeon does a lot. And more surgeons are trying to do that, because if you can do that, you can potentially do that in the office. It doesn't require an OR. The surgical risks are less. And it's a lot more predictable than doing an MSC without the assistance of surgery.
There's one thing I do want to add is that recently I learned technique from my good friend, Dr. Lipkin. He's my classmate, actually. He taught me how to use the Piezo surgery. So it's called the midline Piezo corticotomy. I did a few cases. I really like the approach more so than the quarter punctures because, everybody call me the king of quarter punctures. And I have to admit the piezo surgery might be superior. And then I will tend to switch to that route now. Now, the difference between the quarter puncture that people heard about is for a doll, that's difficult to open. Sometimes we do the tiny little drill, the drill along the midline. We probably put between 15 to 25 tiny little holes in between along the midline to help to weakening the mid-palatal suture, so easier for us to expand. But those techniques work pretty well for the ladies, but for men, we still have some issues. Still have quite a lot of failure. So Dr. Lipkin taught me this technique of using called the piezo surgery. Basically, it's a sonic drill, tiny little drill. The drill probably the paper thickness. The cutting tool I use is 0.035 millimeters. So, basically paper thickness. We're going between, basically split your mid-palatal suture completely all the way to the front. And to my surprise, according to my patient, because I did it on this patient that failed, a male, 23-year-old, failed the quarter puncture and came back for the corticotomy. The second day, we get a split in the middle. We expanded successfully. And to my surprise, he actually told me the piezo surgery hurts a lot less than quarter puncture afterwards. Because quarter puncture drill itself, it's quite a bit bigger, wider in diameter than the thin sonic blade we're going to cut the suture. So I figured the healing part probably easier because it's way thinner, even though we do a continuous cut than intermittent cut. That's probably the reason why it's more comfortable for a patient. The healing is great, and I did a few cases. I had pretty good success with it. So I think from now on, I probably will adopt more to the piezo midline corticotomy procedure versus the older quarter puncture technique that I propose so much.
It's really clean. It's like when I've watched them do the cortical punctures. I mean, cortical with the piezo. It's so clean. It's really, like, whereas like the drill is can be a little bloody.
Yes.
Lipkin is amazing. I call him the MSC whisperer. I mean, he just he does all these custom designs. And I mean, what's beautiful right now is we're getting so creative with these tats. Our arches are narrower and narrower, so the conventional MSE doesn't work. So orthodontists like Richard and Illya Lipkin, I mean, they're customizing these tats. And like I said, his work is amazing. And he's out in New Jersey.
So is that split done in office with the how do you say it? The piezo?
Piezo.
Yeah. So you would do that in office? Just okay.
Yes.
Interesting.
In office under local anesthetic, because the bone itself doesn't have pain nerve. So all you have to do is numb the soft tissue, which is the palate. And then piezo have this important property is that it doesn't really cut soft tissue that much, but it cuts bone quite efficiently. So I have very minimum amount of bleeding, very little blood vessel disturbance. And so bleeding wise is very minimal. It's very surprisingly minimal.
And then after, can the person eat, or does like food go through the split? I know that sounds kind of gross, but does it just the soft tissue heals quickly?
Yeah, those we usually either we use medical grade super glue to seal the wound. Okay. As long as we seal it for the first day, then the soft tissue healing goes really, really fast. So we don't have to worry about infection and stuff like that. My instruction to the patient usually is tell them try not to blow their nose, or don't blow their nose for the first 2 days. Maybe the first day or two, eat soft diet. Don't brush the area. Don't disturb the area. Just let the tissue heals up a little bit. Okay. And then on the third day on, they can go about their normal stuff. But again, just be really careful with the newly healed up gum area. Then that's about it.
Would this type of technique work if the palatal bone is so thin that the screws would be dragged through with just MSC without a surgical approach? Is this another option, or do you typically need to also cut the upper part of the maxilla?
That's a usually I reserve the surgical assist to a patient that failed the first time.
Mm-hmm.
Okay, or to a male patient, I know the patient is pretty old, then older male, then I try to avoid I try to ask patient to go direct to surgical assist with more predictability. Or if the patient is extremely narrow and we can't afford to lose any expansion potential and allowing the screw start tipping. So for those patients, I will try to push them for surgical assist the first time, so we don't have to do 2 MSC, which is not very predictable. Okay, you want predictable result, surgical assist is the way. Okay.
Dr. Tracy, are you able to do these surgical techniques as well with the piezo split and quarter punctures and stuff? Okay.
Yes. I can do it. I choose not to do it.
Okay.
There are many GPs that are doing MSC using the cortical punctures and the piezo. I actually now I'm just leaning towards with my surgeon. So like if I feel like I need to grab my surgeon, I'll have my surgeon just do both the cuts. But I mean, Illya, I mean, he's just doing such amazing work by himself in the office with the piezo. So, and it's beautiful. It's really nice and clean. The problem is like we don't really have a lot of literature on when to do this. Everyone's pretty much just doing it to open it. So we don't have literature to say, is it better to do the piezo? Is it not? What age group do I do the piezo? What age group do I not? We have one article that I think Moon did that looked at CBCT imaging, that looked at the thickness of the palate to see what was most likely going to open. But I think it all boils down to the clinician and what the clinician is very comfortable doing. If the clinician has done a lot of piezos, they're going to do it automatic, whether you can open or not. So like I think Illya probably does it as an automatic now because he knows that's predictable. So it's a decision called not about like, do you need it or not? It's just that it's going to be predictable to do it. So let's do it.
Okay. I have an orthodontist here that's asking me, what's the difference between MSC and Sarpy? How would you explain the difference, Dr.
Sarpy involves a surgical cut. So MSC does not involve a surgical cut, and that's the big difference. Sarpy involves, the traditional Sarpy involves 3 surgical cuts: anterior nasal spine, love fort, and the pterygoid. That's what they've been doing for 20 plus years. That's what most orthodontists know. MSC does not involve any kind of surgical cut. It just involves the placements of tads. So that's the big difference. Dome is a modified Sarpy, but it involves 2 cuts. There's no pterygoid cut.
Okay. So would MSC be like Sarpy, but not without surgery, or does Sarpy not use TADs at all?
No. MSC is a form of what we call MARPy, micro implant assisted rapid palatal expansion. It involves 0 surgical cuts. That's the big thing. Is like Sarpy, the S stands for surgical. So there's a big argument in the orthodontic and the GP world with these uses of TADs. Is it really non-surgical? Some people are calling it surgical, but I mean, Ting, it's for me, and it is not surgery unless you do a cut. So some may argue that the cortical puncture and the cortical piezo, now that you're involving like somewhat of a cut, so maybe that could be classified as surgery, but traditional MSC is not a surgery.
When they do Sarpy, how do they expand? Is it affixed to the teeth or is it boneborne?
So traditionally, before the invention of MSC, it was with a tooth expander, hence the need for 3 cuts. So, and during the surgery, they open it at the day of surgery. With the dome technique and the minimized cuts and the TADs, it reduces that last cut, the pterygoid cut. So it's less cuts, but yeah. Did I answer your question?
Yeah. Yeah, no, yeah, that makes sense because I wasn't sure like what's doing the expansion part when they say Sarpy, and I think a lot of orthodontists aren't familiar with MSC,
Yes.
or the quarter punctures with MSC or the minimally invasive components, so they just say, "Oh, or just do Sarpy,"
Yes.
but you're still if okay, no, that makes perfect sense.
So
Um,
that's what orthodontists and that's the orthodontists and oral surgeons. Oral surgeons, they can do Sarpy in their sleep. They were trained on that. They're trained on 3 cuts. So when you ask them to take away 1 cut, they're like, wait a minute. What if it doesn't open? But they're not but they have to work with an orthodontist or dentist that understands the use of TADs. Because if you have a tooth-borne expander, you're not going to get it open without the 3rd cut.
okay.
So, probably an easier way to. It sounds really complicated because for a lot of doctors who is educated a certain way, they kind of can't see the other way.
Mm-hmm.
So Sarpy, it's actually a tooth-borne expander use, and the cuts very invasive need to be done in the hospital because danger of cutting the maxillary pterygoid suture. There's a lot of blood vessels, so it's a very invasive procedure. The cut is more, and the cost is a lot more because it need to be done in the hospital. And then the expanding device is not an ideal device because it's a tooth-borne device. When I used to do Sarpy, patient would return, the molar is still flaring tremendously with the Sarpy, and I still have to deal with the flare-out molars. The only difference, they get a gap in the middle. So you do get tooth component, the skeletal correction component, but with the extensive side effect of molar being flared out, and patient pay a lot of money for it. And it's a much longer recovery time. They usually get a lot of bruise on the face. Now the MSC by itself, if you do MSC by itself, say for a younger female or a younger male, then it's basically just an expander with 4 little screws. So like Tracy say, she won't consider it a surgery. I wouldn't consider it surgery. So that's the next step. The step after that is if you're slightly older adult male or older female, then we do what we call a quarter puncture. We would drill a serious little hole in conjunction with the MSC to help with the expansion. And same thing as midline piezo corticotomy, achieving better result for the same purposes, just help the midline to open. And a step after that is use for male. For me, it's over 27 years old. Then they will use the surgical assist. Surgical assist is a semi Sarpy kind of cut, not extensive, so they can do it in office. So the cost wise is quite a lot less than Sarpy that do in the hospital. At the same time, less invasive, less chance of bruising or any kind of danger. And also the expander is a lot more efficient because you use the MSC versus the tooth-borne expander that pushed the teeth out a lot. So it's a different kind of expander. We use a lot less surgery involved, so patient comfort wise is a lot better, a lot less invasive than the Sarpy. Sarpy, in my opinion, I would never use it again. It's outdated technique. There are way better things out there. It's like if you have a smartphone, why would you go back and use the dumb phone?
So if someone needed a MSC with surgical assist, who installs the MSC? The surgeon, or are you there for the procedure?
That will depend on which surgeon. Because I work with two surgeons doing those. One surgeon like me to cement the device in there, glue it in, and then do the split, and he'll put in the screws. The other surgeon who basically want me to give him the whole device, they will just install everything. I just have to fit it, make sure it fit properly, positioned properly. And so depends on the surgeon, what they are used to or what they prefer.
Okay. Dr. Tracy, you mentioned marpy. This has always been my confusion is What is MSC versus marpy? What's the difference?
So MSC, so if we think, let's go backwards and let's say, okay, you have RPE, which is rapid palatal expander, right? That's tooth-borne.
Mhm.
You have MARPy, which is micro implant assisted rapid palatal expansion. So now you have the invention of TADs.
Mhm.
Then you have Sarpy, surgically assisted rapid palatal expansion with the invention of surgical cuts. So there are three categories. MSC is a brand of MARPy that is patented by Juan Moon. So
Okay.
MSC, that whole title, so he's like a brand of MARPy.
Okay. It's like a type of marpy. Okay, that's perfect. I never really got that. So people are like, are you doing marpy? Are you doing MSC? I'm like, I don't know. Okay.
Yeah. So, the thing is, MARPy is not new. Like, there are many different types of designs now. MSC itself is a patented device by Juan Moon. So people like Richard Ting, Illya Lipkin, people that are customizing their designs, they're not MSCs anymore. They're MARPy, customized MARPy designs. So MSC is kind of like this brand. So it's interesting because when I have a patient that comes to me and they're like, "Do you do MSC?" And I was like, "I do TADs, and depending on your palate, you may need a customized MARPy." MSC is just a brand.
Okay. That clarifies it for me. Thank you. So question is, we're talking about skeletal expansion, like growing the bone. And I know when you get that sutural split in the midline palatal suture, the bone fills in and it grows. So you're really growing the bone. That's amazing. What are the difference between these type of skeletal expanders and maybe other appliances that they call like growth guidance appliances or that entail like maybe some dental changes, or just to explain? Because there's so many options out there.
Mhm. I'll let you tackle that one, Richard.
Not the specialty on those. I think you know much better about
So,
those.
I think that the key, it's interesting because there is this quest for anterior growth. And the challenge right now is there's a lot out there with a lot of limited research. Um, so the thing is to say that we are getting anterior growth, you really need to ask the provider to show you images like dental x-ray images to actually show that there's anterior growth. There's a lot of these devices that are showing photos of patients' profile, and patients' profile and lip profile can be masked by teeth tipping. I think Richard has seen many, I've seen a lot. I think I respectfully think that there's a place for everything, but I think that there has to be a real discussion on what we are achieving. Because right now there is not a lot of literature evidence on skeletal expansion with growth appliances. And I stand corrected. If anyone is hearing this and they have something, I would love to read it. Just to my knowledge, I have not seen before and after CBCT confirming the skeletal expansion of movement of bone. MSC, which has been out only for 5-7 years. There's a lot of literature. I have a handful of cases where I can show you before and after CBCTs. So I think that for us, for the dental community to really embrace all these different types of appliances, we would like to be educated ourselves in it. So I don't want to say that it doesn't work. I have just not seen the evidence and the radiographic evidence to show that we are getting anterior growth. I know I can only speak for myself and what I'm seeing and the patients that come into my office. I am seeing a lot of dental tipping. But that being said, I just had a 7-year-old in my office that's being treated by an orthodontist, which was where the upper jaw was set back and they flared it out with braces. Now, this is no appliance at all. This is just conventional orthodontic treatment. Mm-hmm. Now, I would probably have put that 7-year-old in a reverse pull face mask, versus the dental tipping. And again, this is not growth appliances. This is just conventional orthodontics. So I think it has to do with the dentists and the orthodontists and their philosophy of what needs to move forward. Would you see, I don't know. It's like, so I can argue that this orthodontist that on a 7-year-old that just expanded and tipped the teeth out and corrected the bite, yeah, I don't think you got any skeletal movement there. So that's no different than putting a growth appliance. You didn't really get any skeletal movement there.
What about in an adult? Is it possible, like, could any dental movement or dental tipping be beneficial to allow more tongue space, or you're at the risk of, tooth-borne tooth issues? Mm-hmm.
So I always say, what are you treating?
Mm-hmm.
And I think that we kind of forget about that. Like, I'll get a patient that comes in and goes, I have sleep apnea. And I was like, okay, so what am I treating? I'm treating my sleep apnea. Okay, well, what's getting more tongue space going to do for that? You know what I mean? So I feel like we have to take a step back and really ask, like, diagnostically, what are we treating? What is our expectations of our dental treatment? If you have obstructive sleep apnea or sleep disordered breathing, is flaring your teeth giving you more tongue space? Is that really enough?
Mm-hmm.
Like, based on the literature, what's the best thing for that? Based on the literature, we have stuff on maxillary expansion. We have stuff on Sarpy. We have stuff on double jaw advancement. Based on the literature, we have nothing on anterior growth guidance and moving the tongue forward. So if we're treating obstructive sleep apnea, sleep disordered breathing, we have to get back to that diagnosis, versus just throwing whatever's a trend right now. And so, like, I always like to, when I get my patients that want certain things, it's important to kind of be like, well, what am I treating?
Mm-hmm.
And then you can decide what you're going to do.
Because we want it all, right? Like, just grow my breathing tube and everything. So then the MSC type approach, it's only transverse. There's no AP growth. Is that correct? Or Dr. Ting, do you want to?
Okay. So first of all, I want to say I completely agree with everything Tracy said. Okay, completely agree. Now, this is how I started treating Airway patients more than 10 years ago when I was treating in my closet, not telling anyone. We'll tell you a story about me and Tracy at the end, how we know each other, how we talk about it. That's so long ago. So back then, all my concentrating on is to make the lower jaw come forward because there's no MSC. Okay, so transverse is not in the picture. So I realized when I make the lower jaw come forward, patient can breathe better. We have this marathon runner or cross-country runner. After I make the lower jaw advancement, back then I used Herb's appliance. He came back as so excited. He said his record time is increased by 4 minutes, which never happened before. So he consistently can breathe a lot easier, which is very exciting. And then I got in touch with the MSC. And then I realized MSC really revolutionized the whole industry of orthodontics and Airway. When I was educated on MSC in Wong Moon's seminar at the very beginning, nothing about Airway is mentioned. Okay, I think Tracy and I talked about Airway before Wong Moon even brought the Airway to the picture in the MSC. So I realized that after I do the skeletal expansion, the majority of my patients that I diagnosed that need double jaw surgery, after the expansion, they denied the surgery because they told me their obstructive sleep apnea is completely cured. They claim. Okay. I didn't test them. But that's the result I get. So I found out one thing is the transverse is actually, I believe, I don't know if Tracy agree, is I think transverse discrepancy skeletal-wise is one of the most important factors in correcting airway. It's the most important factor. Because once you increase it, not just increase the nasal volume, you also increase the pharyngeal space, also you tighten the soft palate. So it's the most important factor. And I personally believe the lower jaw position, forward and backward, is the second most important. Okay. So transverse discrepancy probably take away 70-80% of credit. And the other 20% credit take away the lower jaw. Okay. Now, the upper jaw forward, backward, to me, is not a super important factor. Okay. A lot of growth guidance appliances, they push the upper jaw forward. To me, the upper jaw position, how far the front teeth goes, doesn't really affect any of the treatment. Or there's no significant factor. Okay. Now, tongue position-wise, I think it's probably the third or fourth important factor about the tongue position. But the lower jaw pretty much dictate a lot, and also the palatal width that makes a major correction. So there's a factor of importance, in my opinion, with all the patients I treated. And once I corrected transfers, majority of the patient basically claim by themselves they're cured. They don't want to go any further to any other kind of intervention, which is frustrating for me. but I respect that because they get a majority improvement. So there's a important of orders. I believe tongue correction, it's very important. I believe lower jaw correction is very important next to the transfers correction. But I think transfers dictate a lot of that's probably one of the most important factor. And where the teeth position to me is not as important. And in my office, we want to do an extraction case. For example, last year I did one case. The year before I did two. This year probably won't have 1 or 2 cases out of all my patients gonna have extraction. My extraction guideline, basically, I gotta expand you first. After I expand you, I make sure you can breathe properly. Then I feel comfortable doing extractions, and patient will not get affected afterwards doing the extraction. Okay, so the main purpose of extraction is patient have a lot of flair in the front teeth that's biologically not healthy because it's basically the tip out of the bone. So after we extract it, we'll put the teeth back into the bone in a much healthier position. Okay, and patient will not get affected at all from the front teeth tipping in with the extraction after the expansion. And for those growth guidance devices, I never tried them before. All I see is damages because I have a lot of patients, same thing as Dr. Tracy, a lot of patients come in with tremendous amount of bone loss because the front teeth, either upper front teeth, lower front teeth, or even the canine get pushed almost completely out of bone with just a little piece of bone supporter. Basically, I can flick my finger, the tooth might probably come out. We see a lot of those. And those patients, sometimes I feel really bad for them because I'm even afraid to treat them. Because if I start moving those teeth might come out. So I see a lot of bad side effects of those appliances. Not saying that they're all bad, but for the patient to come to seek my help, they're all bad. Maybe the good one never come to see me. I only see the bad one. So it's a selective pool of patient that I gain the knowledge from.
Mm-hmm. You know, we're seeing a lot of things come back like full circle, and I think it's beautiful that that you're doing this, Nicole, because like I think the function and form is starting to come hand in hand. Like if we go to look at the history of sleep surgeries, it was always anterior posterior movement, you know, just bringing everything forward. Well, you know, not double jaw advancement is not 100% successful, you know. So then the more recent study kind of came out, started looking at nasal resistance. So obviously then the Stanford group brought in dome. They're like, okay, let's do transverse. Let's get them breathing better. If we can improve the resistance in the nose, we can decrease the collapsibility of that airway. So then we start talking about transverse. Then the most recent study just came out this year from the ENT group that looked at the intermolar widths and what does it do to tongue function. So now we're coming full circle with anatomy. Possibly the tongue is responding a different way based on the anatomy, you know. And so in that most recent study showed that if that intermolar width was about 28, 29 millimeters, that the tongue would have that tendency to functionally drop back, you know. So then you have another issue of collapsibility. And so I think now we're coming full circle with, okay, it's not all about anterior posterior. It's also about transverse. So now let's take it back. It's yes, it's anterior posterior. It's also transverse. And the third one, it's also the function of the tongue. So that is where myofunctional therapy and retraining respiratory breathing comes in place. So we're finally getting into a point saying like, okay, it's not one thing anymore. It's like this quest for AP. You have to look at the transverse, then you have to look at the function. I mean, I think it's a beautiful time now because everyone's kind of talking together.
I love this. Now you just made me feel like I have to bring out my little drawing that I'm obsessed with. So my mentor, Katha Fair, who was over 50 years certified orofacial myofunctional therapist, taught me this. And I just feel like it applies to what you're saying in all these cases. So I need to like share my screen to show you guys. I always do this. So when we're evaluating and treating any dysfunction in the oral cavity, we must look at the interaction of these three systems. To me, I feel like this makes things somewhat black and white, even though it's not black and white. And there's always kids that are different. It just puts things together. So what she taught me is that these three systems work together as a team, and any dysfunction or altered functional pattern in any one of these can affect the others, contributing to problems in the oral cavity. So we must look at the myofunctional system, so soft tissue and muscle dysfunction. We must look at the medical system, any medical factor that may influence how the muscles work, like nasal issues with nasal patency, allergies, enlarged tonsils, tethered oral tissues. And then we must look at the dental system and how skeletal and dental issues affect tongue posture and correct oral rest posture. So if there's a narrow palate, deficient growth, issues with the maxillary mandibular relationship, even appliances that can affect tongue posture can also cause problems. So from a myofunctional perspective, we say that an understanding of why the tongue is not functioning in the neutral position is not complete unless it identifies all the factors that are capable of causing or contributing to incorrect tongue rest posture. And then when we talk about sleep disordered breathing, we have to look at the airway from the tip of the nose all the way down the throat. And a key challenge in this evaluation process is to identify the multifactorial causes. And so I feel like when you said that, Dr. Tracy, it just like, yes, it's function and its form. And for me with the MSC, I felt like I got some forward growth. I'm not saying of the teeth and the bone, but actually tongue posture. So I could not breathe with my chin down. I could not inhale. I'm like, oh my gosh, this is really weird. Like I'm like, I can't do yoga and things like this because I feel like I can't breathe on my back. And with my chin down, I had to go into a class 3, bring my jaw forward to get
Don't
hair.
talk to Tracy about yoga.
I know. I'm jealous. And her Peloton and all these things. She's amazing. So after the MSC, what I felt, and I had major tongue scalloping as well, which is like almost gone now. But I felt like my tongue didn't only widen where the tongue can fit better, but my tongue could actually come forward out of my airway, out of my throat. So to me, that's sort of AP, even though it's not like maybe what you refer to as like AP skeletal growth, but I can actually inhale. I'll prove it. Okay. And I took a deep breath in. You probably couldn't hear, but it was through my nose. And it feels like it's actually abdominal diaphragmatic breathing. When I do that, I can get air because my tongue has space to come wide and out of my throat. And that felt really interesting to me to feel that change, even though we just widened. And hopefully it's enough. Maybe it's not. I don't know. But I definitely feel a lot better. And I know there's some research. I believe I heard Steve Karstensen and Kevin Boyd talk about in children, RPE is actually causing some AP growth at the posterior pharyngeal airway. If I'm saying this correct, they're noticing like there's more space like for adenoids, and the space at the back of the throat is actually increasing. It's not just doing transverse expansion.
Yeah.
Are you familiar with those? I'm sure you know all the studies, Dr. Tracy, but I think Dr. Kevin Boyd is doing a study right now in his office on that. Is that correct? Do you know?
Yeah, I mean, I think the beauty with everything that's going on now is like, before now, all the studies is about like one procedure. How successful is this one procedure? And because that one procedure wasn't 100% successful, people are like, okay, then that doesn't work. Now we're looking at, well, what if we do this and this and this? And that's the key here. Just like you said, like you might not need all this massive anterior posterior. All you needed was enough to get you functioning better. And so you have like a little, and I think that's kind of where the missing link is getting people together to talk about it and working together.
I have to advocate for I'm a myofunctional therapist, so muscle tone is so important. So as like the icing on the cake, the cherry on top, add that myofunctional therapy component to help maintain the stability of the arch, the breathing, the airway. We've got to increase muscle tone, get the tongue up, lips closed. I know in a lot of children, Dr. Ting, and some adults, you do the reverse pull face mask or the projection face mask. Can you talk about how that goes along with MSC and how you use that? I know you've said it's non-surgical MMA, which I think is such a neat term. Can you just describe that?
Yes. You both of you probably saw the picture. I treated a patient, non-surgical MMA. So the theory behind it is when you do skeletal expansion, you actually activate all your sutures. You loosen up all sutures. So during the first expansion, between the first month or two, we actually be able to drag your upper jaw, not the teeth, the whole jaw forward. Okay, and so we have some forward movement. I have quite a few documented cases showing that happening. Okay, now, however, my success is more limited to younger adult in the 20s. Okay, and the later patient, we still have problem getting them where the headgear that they are supposed the time they're supposed to. My regimen is 14 hours a day minimum. Okay, to wear those appliances, and so far I don't have any luck with older adult be able to use that much of time. But then the younger adult, 23, 24-year-old, they actually, if they wear that amount of time, I can see improvement. So I want to say it's a hit and miss. And I don't want to say the technique itself had problem because for patients who actually wear them, they work. So I think more it's the reversible headgear depends way too much on patient's cooperations. So that makes it unpredictable. The patient actually had to put it on, and it's a cumbersome device. No matter what kind of headgear you use, all reversible headgear bothers patient. There's not a comfortable one. So depends on patient usage. When patient use it, I think it's a wonderful device. I can move the maxilla 4 to 5 millimeter. Okay, not so much mandible. Mandible I can move forward even 7 or more millimeter with the Invisalign mandibular advancement device. So it is a device that proven successful, but it's also a device proven have very, very, very poor compliance.
So just so I understand then, for skeletal growth of the maxilla, like true skeletal growth, is reverse pull
yes.
headgear the only
with
way?
MSC.
With the MSC, that's the only way to get for non-surgical forward growth in a child.
Yes.
That's, okay.
In my opinion, unless somebody else research is proven otherwise.
But did you have something to say, Dr. Tracy? I could see you were like nodding.
Oh no, he's right. I mean, there's different types of reverse pulls. Obviously, I mean, there's different types of masks. I mean, now we're doing little mini anchors in the jaws to bring them forward. But the whole concept is the same. Like you're doing skeletal advancement of the upper jaw. And yeah, versus like the anchorage is actually on the jaws, not the teeth.
For the MSC in general, because it seems like there's just some specialists that do this, but I don't think anybody in my area does this. And I don't think a lot of people even know about it. Why do you think more practitioners don't do the MSC approach?
You can answer that, Richard.
Okay.
Throw it on me.
I can tell you why.
Throw me under the bus right now.
I can tell you why.
You don't have to answer. I don't know if that's an awkward question. I'm just wondering, is it just newer or?
I can tell you why GPs are doing it, and Richard can tell you why orthos aren't.
Oh yeah, take it for the ortho team, Richard. No. You don't have to answer. I just don't know.
So who go first?
Honestly, it's a good question. It's a really good question.
So for the orthodontics is a very business. That's why a lot of people want to get involved in orthodontics. Now, in the past, I don't know, 100 years, I don't know, orthodontists been working the same way, which is a teeth-focused approach. So when they look at a patient, they look at how do I make this patient teeth straight? They don't look at your face, they don't look at your function, they don't look at your structure, they don't look at your airway. So all they do is concentrate looking how your teeth can get fixed, can get straight. Now, the easiest way to straighten your teeth is basically take your teeth out. Once you take your teeth out, a tons of spaces, put a wire in, any person can straighten your teeth. So they've been making business like this for the past, I don't know, 100 years. They're pretty happy with it. Okay. They're pretty happy with it. They make a lot of money. Life is good. Doesn't require a lot of, advanced learning, even though it's 10, 11 years to get the college degree to do that. But it's a good money generating business. You see a lot of patients. A typical orthodontic office see about 100 patients, 72. I even know office see 150 patients, 180 patients a day. So they generate a lot of income by just simply straightening your teeth. When this new thing comes in, next thing you know, we can correct the structure, not just straighten teeth. Okay. And correcting structure is very important because straightening teeth becomes secondary. So they have to learn the whole thing over again, disturb the whole system, because correcting structure require more work, like putting the MSC, anesthetize patient, going over details instructions, and sometimes they're failure and learn how to deal with it. It's a complete new language you need to learn. So for doctor who practiced 10 years, 20 years, or been taught like that all their life, they're resisting to it because their income may change for the less, because they won't be able to see their 180 patients anymore. And there'll be a lot of stuff they won't be able to see anymore. They can't just dedicate their assistant to everything anymore, because a lot of office, they basically go in, you don't even see the doctor. The assistant just have a system that will changing the wire and everything. So MSC disturbed the whole industry. The whole concept of structural correction changed the whole industry. And that's why a lot of people are resisting it. As far as I know, a lot of orthodontists doesn't even have the EA license. And they haven't given injection for the past 20, 30 years. So to them, to pick those up, start prescribing antibiotics, learn how to do injection again, that alone enough is enough of a resistance to do it. Okay. Now, if they start thinking about, okay, I might start doing it, but if they don't do it themselves, then they have to send to an oral surgeon to do it. Oral surgeon, their double degree, MD and BDS, they charge you a whole lot more to put in the MSC than you can do it yourself. So the cost becomes much higher. So that increases the patient resistance. Okay. So most people rather not to learn this new technique because they've been fine for the past 100 years. They're happy with the system, despite if you're really doing a service with the patient or not. They're happy to just straighten the teeth, do everything else like the people before them. Okay. Keep the industry still the same way. And that's why you have so much resistance. The second thing is there's not many qualified people go out there to teach. I don't teach. It took Dr. Tracy a long time to convince me to have my first seminar.
Nobody says no to Tracy. No, joking.
No, she's a bad influence. Now I'm addicted to seminar. So that's another big part. When you go to school, most likely all the professor, instructor, none of them have experience with MSC. So nobody feel comfortable teaching the resident how to do MSC, except if fortunate enough to be in UCLA previously, not anymore. Dr. Woman's gone. My brother's gone too. So nobody's actually doing MSCs anymore. And so there's a generation gap. There's no enough people to train the new people. Not enough people know enough stuff about MSC to train. So there's a big gap between the MSC user like on 500, almost 580 cases versus 99.9% orthodontists at 0 cases. There's a big gap between that cannot be filled. Now, general dentists, on the other hand, are completely different breed. Okay, general dentists are always hungry for knowledge. It's good and bad. Bad thing is sometimes they'll adapt to some kind of a device that's not research proof. They bind to that. The good thing is they want to learn. So general dentists become very, they have the knowledge quest for learning how to do MSC a lot of, and do orthodontic treatment. I think this is the MSC is actually a game changer for them. And the example I give it to patients is if I ask the interior designer to design a rectangular sized room, and there's a giant pole in the middle, you cannot move it. So the interior designer had to come up with all kinds of tricks, all kind of camouflage and stuff like that in order to make the room nice and presentable. But if we remove the structure component, become a blank sheet of paper, then any interior designer go in there make a beautiful job. Okay, so the concept of structure correction is once we provide the proper structure, it makes it much easier for any dental professional, including general dentists, to start their own orthodontic treatment. Because if the structure is corrected, there's no fancy mechanics involved, no fancy move that only orthodontists know how to do. Basically, it's a blank sheet of paper. You can do whatever you want to do. So after structure is corrected, the orthodontic treatment become easily treatable and diagnosable. So easy for the general dentist to step in, start treating ortho, if not better, just as good as any orthodontist.
That was a great summary. That was really interesting. I totally appreciate that explanation. And I don't want to take advantage of your guys' time because I know we're probably just a couple minutes over. I forgot to set my stopwatch when we started, but just so people know, also in this technique of MSC, you are fixing the aesthetic look of the teeth. Like I know people have asked me, "Oh my gosh, you're going to look like that." I'm not going to have a gap. The patients aren't ended with a big space in their teeth. So with Invisalign or whatever ways different practitioners use, the teeth will be realigned. And maybe sometimes they have to put cosmetic bonding on the teeth or whatever, but the airway is first and then the aesthetic dental component does come second. And if I'm saying anything wrong, of course, you guys can finish off, but I definitely want you both to just let people know how they can get in touch with you if they have questions, want to seek this treatment or have any inquiries. And of course, Dr. Tracy can talk about the ASAP group as well. So would you like to go first, Dr. Tracy?
So I am the person with 60,000 emails. So email is probably a good way to talk to me. I try to be active on social media. People can always message me on there. You try to get in touch with me however way you can, I guess. All of my social media platforms are public, and I made it public, 5-6 years ago because I felt that dentistry really needed to jump into this airway movement because I felt like interdisciplinary care was super important. And then obviously that's how we all met, through my public forums. So you can definitely reach out to me and follow me that way. ASAP is something that's very dear to my heart. When I started this journey, and Richard's really right, like GPs, general dentists, I mean, we're very hungry for information, but also that when we feel like there's a cause, we feel like a need to bring people together. One thing dentistry does really well is interdisciplinary care. I mean, like for GPs, we know that when we have a big cosmetic restorative case, we grab the oral surgeons, we grab the orthodontists. So we understand interdisciplinary care better than any profession. Now I'm going on a tangent. But when I got into the airway movement, it's really easy to get lost in all these different devices and appliances. And so in my journey, I kept on taking courses and courses, and I kept on getting lost and not understanding it. And that's where ASAP came. We came together, me, Michelle Weddle, Stacey Ochoa, and we put together a platform basically to put all the pieces together. Like if I was early on in my journey and I wanted to learn, how would I like to learn? And that's what ASAP is. It's an online education. We talk about the medical component, the structural component, the functional component. And while it is geared towards kids, we do talk a lot about adults. And on a side, I get a lot of speakers to speak and host courses, selfishly because this is how I learn. But yeah, I mean, pretty much to get in touch with me, you just join me on Facebook and Instagram.
You're the research lady. It's so because you're always presenting
on research.
I love that. You'll summarize the articles and go through it. So I have you saved, so much of what you say saved on my social media account. I'm like, gotta read this, gotta listen to this. So thank you for that. And Dr. Ting, how can people get in touch with you?
Yes. Well, before I talk about that, I want to say, thank you for Tracy. Tracy is such an awesome person. I think she's the reason why I got out of class of treating Airway on my own, secretly, hiding, afraid of the community. I remember I probably met on this myofunctional Facebook group. I eventually got out of the group because that group was really hostile to orthodontists. But from there, I got a lot of encouragement from Tracy, and I realized, hey, I'm not the only one seeing the aliens. She saw the aliens too. And her approach is completely different than mine. My approach is, okay, how do I make improvement clinically? So I'm a very clinical person. How do I make everything better and structure bigger, wider, and improving breathing? And she's very research oriented. She's very seeking information everywhere oriented. So she encourages me a lot. She's been asked me to do seminars so many times, and eventually I came out and do some seminar. And so even before the MSC started, we were exchanging information about the herb supply and make the lower jaw grow for my courage to come out of class. Right now, I'm very known in this area because of her. Okay, because of her encouragement. And how to contact us is we are on social media too. We have a Facebook page, my Ting Orthodontics, or sometimes you can search Ting Ortho. My office is located in South Orange County, Rancho Santa Margarita. And you can also email us at info@tingortho.com. We do open our email because I don't have 60,000 email like okay, so they can message us on our Facebook page or send an email to info@tingortho.com to contact with us.
That's great. Thank you both so much. It's so great to have this combination of Airway dentist on the East Coast, Airway focused orthodontist on the West Coast, coming together, discussing all of this important information that really is helping to save people's lives. So thank you guys so much.
Thank you.
And I think this is going to help so many people with this information. I learned so much too. So thank you.
Thank you for having us.
All right.
Good night.
Thank you guys.
Thank you. Bye-bye.
Bye.